Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite. Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. Thank you for joining me on this journey. As you may know, we've pretty much gotten through all of the preclinical content that's covered in a typical 2-semester human anatomy and physiology college course. So now I'm shifting gears, and this episode marks a new beginning. We're going to go from preclinical, normal human A&P to clinical topics. From now on, each episode will cover a specific disease, condition, or injury. I intend to go from defining it, maybe giving a little bit of a background to the A&P so you don't have to re-listen to episodes from the past. We'll go to signs and symptoms, lab findings, treatments, complications, prognoses, etc. As much as possible, I'll have a guest on who is either a clinician who treats the condition, an individual living with it, or someone along those lines. I think this is going to be more than just for A&P students. This is going to be for anyone who is interested in what goes wrong with the human body. Anyone who is interested in health. Not just healthcare practitioners, but anyone who wants to know what are these things that I keep hearing about. Coronary artery disease, cancer, Alzheimer's, diabetes. What are these conditions exactly? And what do I need to know about them? And I think that's going to be a big shift in this show, moving from mostly targeted to students to now targeted to everybody. As always, I want to preface this episode by reminding listeners that this show is purely educational and is never intended to be taken as medical advice. And by no means should you allow this show to be a substitute for seeing an appropriate medical professional. If you suspect you are not well, or if you have any of the signs or symptoms you hear about in this episode, you should contact your medical doctor immediately or go to your local emergency room. So having said that, today we're tackling one of the most important and common diseases in human health, the single most common cause of death in the history of human beings, and that is coronary artery disease, often shortened to CAD, also known as ischemic heart disease. This is the classic clogged heart artery story, but if we leave it at that, we miss the real anatomy and physiology of what's happening. The coronary arteries are the arteries that supply blood to the heart muscle itself so it can continue to contract and pump blood to all of our organs, like the liver, kidneys, and most importantly, the brain. Coronary artery disease affects those specific arteries and isn't just about a narrowing of tubes. It's about the supply and demand of oxygen. It's about the endothelium of those arteries. It's about inflammation and plaque stability. And in all too many cases, it's about that moment that the heart's energy needs exceed what the coronary circulation can deliver. By the end of this episode, you'll be able to explain coronary artery disease from the ground up with some terms you may have heard, but don't really know very well. You'll learn about the coronary anatomy that makes the heart's muscle tissue vulnerable, the pathophysiology of atherosclerosis, which is what causes the narrowing of the arteries, the difference between stable angina and acute coronary syndrome, what labs like troponin actually mean, how we diagnose CAD with ECGs, stress tests, and angiography, and the logic behind treatments from statins to stents to bypass surgery. Now, the kind of doctor who diagnoses and treats coronary artery disease is called a cardiologist. Cardiologists are basically heart doctors. Some are internal medicine physicians who specialize in diagnosing and treating multiple ailments of the heart, like arrhythmias, heart failure, coronary artery disease, and others. Some are cardiothoracic surgeons, and when necessary, they perform some of the more invasive procedures I'll be discussing later on. Okay, so let's talk about coronary artery disease bit by bit. I'm going to explain as much as I can without this being too lengthy, but if you are worried you don't know enough about the normal A&P of the circulatory system, you may want to listen to the episodes that cover it. It's a huge system, so it turns out to be episodes 39 through 48 of this podcast. Blood, blood vessels, and the heart. But in case you don't have time for that, I'm going to start with a quick review. The heart is a muscle, and like every muscle, it needs oxygen and fuel. But the heart has a unique problem. It can't extract enough oxygen from the blood passing through its chambers to supply itself. The heart's muscle, called the myocardium, depends on its own dedicated circulation. Those are the coronary arteries. As mammals, we have a four-chambered heart, two smaller upper chambers called atria, and two larger lower chambers called ventricles. The right atrium receives blood from the systemic circulation by way of two large veins, the superior and inferior venae cavae. From there, the blood goes into the right ventricle, which pumps blood into the pulmonary trunk, which then divides into pulmonary arteries that carry blood toward the lungs. After the lungs are done exchanging the blood's carbon dioxide for oxygen, it heads back to the heart via the pulmonary veins, which deliver it to the left atrium. Blood goes through the left atrium and into the left ventricle, which pumps it into the ascending aorta, which eventually diverts blood to the coronary and systemic circulations. The human heart in quite a small nutshell. The two main coronary arteries branch off the base of the ascending aorta just a tiny bit above the aortic valve, which is what regulates the flow of the blood from the left ventricle into the ascending aorta. There are two main branches coming off that ascending aorta, the right coronary artery and the left coronary artery. You can probably guess which side of the aorta each one of those is on. And like I said before, you can review the coronary circulation in depth in a previous episode, but for this episode, we'll focus on the most clinically significant coronary arteries, the left coronary artery and its main branches. The left coronary artery quickly divides into two major branches. The left anterior descending artery, which runs down the anterior between the left and right ventricles. This is also known as the anterior interventricular branch. And the left circumflex artery, wrapping around the left side of the heart. Clinicians obsess over the left anterior descending, or LAD, and for good reason. It supplies a big chunk of the left ventricle and the interventricular septum, which is the muscular wall between the two ventricles. These structures are essential for pumping blood to the systemic circulation. You'll sometimes hear the LAD nicknamed the widowmaker because when it's severely occluded, the risk of a fatal heart attack is high. I don't love this nickname, mind you. It's a little insensitive for my taste. Also, coronary artery disease is the number one cause of death in biological females, not just males. Now here's a crucial physiology point. The coronary arteries fill mainly during diastole, which means in between beats, when the cardiac muscle is relaxed, not during systole when the cardiac muscle is contracted. When the cardiac muscle is contracted, it compresses the coronary vessels, especially ones embedded deep in the myocardium. So the heart gets most of its own blood supply when the ventricles are relaxed. That means anything that shortens the time in between beats reduces the amount of time the heart has to get fresh, oxygen-rich blood. And anything that raises the pressure in the left ventricle, like high blood pressure, hypertension, or a thickened left ventricle known as ventricular hypertrophy, can also worsen coronary blood flow. So coronary artery disease is not just about the size of the pipe, it's about flow dynamics, timing, and demand. Let's think about that time in between beats. You've heard that having a lower resting heart rate is healthier. Well, think about it. If your heart beats 90 times per minute, you're going to have a lot less time in between beats than if your heart beats 70 times per minute. The more time in between beats, the more often your heart is perfused with oxygen-rich blood, making sure it has a constant flow of the oxygen that it needs to make ATP. So that's as simple as that. The actual time it takes to actually contract the heart doesn't change all that much when your heart rate goes up. It's really the time in between that changes. Let's check the math on this. Let's say it takes about 1/3 of a second for the ventricles to contract regardless of heart rate. This number varies a little bit, but we'll use it as an average. If your average resting heart rate over 24 hours is 70 times per minute, that means that every minute the ventricles spend 23.1 seconds in the contracted state, getting very little blood to the myocardium. And that's not that bad. A resting heart rate of 70 is good. That's kind of what you want. But if for some reason your resting heart rate is 90 beats per minute, the ventricles are contracted for 29.7 seconds every minute. That is 6.6 seconds more of ventricular contraction than if your heart rate was 70. Another way to say that is 6.6 fewer seconds that your heart spends in between beats. And that is when the ventricular myocardium is perfused with blood. There are 60 minutes in an hour. Multiply that 6.6 seconds by 60, and that means that every hour of the day, your heart is getting 396 fewer seconds of blood supply if your heart rate is 90 versus 70. So it is much better to have a lower resting heart rate. How do we keep a lower resting heart rate? Aerobic exercise and maintaining a healthy body weight. The lower weight means the heart doesn't have to work as hard, and exercise trains the heart to pump blood more efficiently so it doesn't have to beat as often. Coronary artery disease becomes clinically important when it limits blood flow enough that the heart muscle becomes ischemic, meaning it's not getting enough blood to the tissue. Ischemia happens when blood supply decreases, which can be caused by arterial stenosis, which means a narrowing artery, spasm of the arterial muscle constricting it, a blood clot known as a thrombus, low blood pressure, or anemia, meaning there is less oxygen in the blood that's coming in. Ischemia also happens when the demand for oxygen-rich blood increases, caused by exercise, stress, fever, elevated heart rate, which we call tachycardia, or high blood pressure, called hypertension. If the demand for oxygen-rich blood increases but the supply does not, then we have a problem. That problem is called ischemia, which is the restriction or reduction of blood flow to tissues, causing a shortage of both oxygen and essential nutrients. When the oxygen available to the tissues in question gets too low, it's called hypoxia, and that is when tissues begin to fail and die. Ischemia, the lack of blood flow to a tissue, will always lead to hypoxia. However, hypoxia can occur without ischemia. Even with normal blood flow, if the oxygen level in the blood itself is too low, like with altitude sickness or lung disease, hypoxia may follow. So the mismatch between supply and demand affects cardiac metabolism fast. The myocardium loves making ATP with aerobic respiration, but when oxygen becomes limited, the cells shift toward anaerobic pathways, generating less ATP and more metabolites like lactate and hydrogen ions. Those contribute to pain and dysfunction. Ischemia also disrupts ion gradients, impairing contraction and electrical stability, setting the stage for arrhythmias, which are abnormal rhythms in the way the heart beats. And that leads us to the big question when it comes to coronary artery disease. What causes the decreased supply? Demand is always going to be up. You need blood in your heart, and you're going to do things that make you need more at any given time. So really, we're talking about the supply. Why is the supply declining? And the answer is something you may have heard of before, but maybe you're not 100% sure what it is. And that is atherosclerosis. Atherosclerosis is not simply fat stuck inside of an artery or hardening of the arteries. It is a chronic inflammatory disease of the arterial wall. It begins with endothelial dysfunction. Remember that the endothelium is the simple epithelial tissue that lines the inside of a blood vessel. It is simple squamous epithelium. But the endothelium isn't just a passive lining. It actively regulates the following conditions: its own vasodilation using nitric oxide to relax the arterial smooth muscle, platelet activity, which promotes coagulation of blood, and inflammation. When the endothelium is injured or stressed, it becomes more permeable and stickier, allowing lipoproteins, especially LDL cholesterol, low-density lipoproteins, to move into the arterial wall. LDL becomes oxidized, and that triggers an immune response. White blood cells called monocytes enter, turn into macrophages, and start eating the lipid, becoming foam cells. This forms a fatty streak which can evolve into a mature plaque with a lipid-rich core, a fibrous cap, smooth muscle proliferation, and ongoing inflammation. Now, plaques are dangerous in two main ways. One, they gradually narrow the vessel. Remember, we called that stenosis. This limits blood flow, especially during increased demand. This is the classic setup for stable angina. We'll talk about this a little bit later, but stable angina is chest pain or discomfort that occurs predictably with physical exertion or emotional stress and is relieved by rest or medication. It is a warning sign for underlying heart problems, though. Symptoms can include chest pressure or squeezing and may spread to the shoulders or arms, while other signs can include shortness of breath, dizziness, nausea, and fatigue. The other thing that can happen with plaque is a sudden rupture. If the fibrous cap is thin and inflamed, it can rupture, exposing thrombogenic material and triggering clot formation. That's the setup for acute coronary syndrome, which can be any of the following three conditions. 1. Unstable angina. Unstable angina is a high-risk medical emergency characterized by unexpected, severe chest pain occurring at rest or with minimal exertion, often signaling an impending myocardial infarction, also known as a heart attack. It could be NSTEMI, which stands for non-ST elevation myocardial infarction. It's a type of heart attack caused by a partial coronary artery blockage, which reduces blood flow and damages the heart muscle. The ST refers to the interval between the ventricular contraction and ventricular relaxation that can be found on an ECG. In this case, the ST segment is not elevated. And finally, STEMI. A STEMI is an ST elevation myocardial infarction. It is a serious type of heart attack caused by a complete blockage in a coronary artery, which stops blood flow and causes damage to the heart muscle. In this case, the ST segment is elevated. Symptoms include chest pressure or pain, shortness of breath, cold sweat, and pain radiating to the arm, neck, or jaw. Prompt treatment with angioplasty or clot-busting drugs to get blood to the heart muscle ASAP is crucial to restore blood flow, limit heart damage, and improve survival rates. An angioplasty is a procedure in which a catheter carries a balloon to the affected artery and inflates it, opening the vessel and then permanently installing a stent. A stent is a small, strong, mesh-like tube that holds the vessel open. There are multiple kinds of stents, but I don't want to get too more into the weeds than I already am in this episode. Oh, and here's an important twist. The most dangerous plaques aren't always the ones that cause the most narrowing. A plaque that narrows the lumen 40% might be invisible on symptoms until it ruptures and forms a clot that suddenly blocks the vessel. So coronary artery disease is both a plumbing problem and a stability problem. And think about this, the narrower the vessel, the smaller the clot that can block it. So if the vessels are really nice and open and patent, a tiny clot isn't going to block it. But the narrower they get from atherosclerosis, the more susceptible they are to being blocked by a clot because it doesn't take much of a clot to block it. Let's do some more math to show why a narrowing coronary artery affects blood flow so much. Blood vessels contain blood by imposing a peripheral resistance on it. That basically means that the blood can't squirt out because a vessel has walls. So there is resistance, just like the water in a garden hose can't spread all over your lawn because the hose is giving it resistance. So it has to go in the path that the hose is allowing it to go. The mathematical formula for calculating the resistance a vessel imposes on its contents takes into consideration the radius of the vessel, the viscosity or thickness of the fluid contents, and the length of the vessel. We will use Puiseuil's law to figure this out. According to Puiseuil's law, as it pertains to peripheral resistance in the circulatory system, the resistance to blood flow increases as the radius of a vessel decreases, meaning the narrower the vessel, the greater the resistance. Try sucking water through a very narrow straw versus a wider one. You'll see what I'm talking about. Here's the kicker. When I ask my students how much they think resistance increases when plaque formation causes an artery's radius to be half of what it normally is, they usually guess half. But that is not the case. The proportional increase in resistance is calculated by taking the change in radius to the fourth power. So let's look at an example where we are only concerned with the proportional change in resistance as vessel radius changes. We will use a measure of 1 for the viscosity, length, and constants in this equation because they don't change when a vessel constricts or dilates. If a vessel has a radius of 2 millimeters, in this example, the resistance would have a measure of 1/16 of a liquid ohm. That's the unit resistance is measured in. Remember, radius to the fourth power. 2 to the fourth power is 2 times 2 times 2 times 2, which equals 16. But what if plaque formation cuts that vessel's radius in half to 1 millimeter? Then what's the resistance? 1 to the fourth power is 1 times 1 times 1 times 1, which equals 1. The resistance goes up to 1 whole liquid ohm from 1/16 of a liquid ohm. So the resistance to flow increases 16 times when the vessel radius is cut in half. Since flow is the inverse of resistance, that means blood flow decreases by 16 times when a vessel radius is cut in half. Imagine that, blood flow to a section of the ventricular myocardium decreasing by 16 times just from a 50% reduction in radius from plaque formation. That is enormously significant when it comes to myocardial perfusion. Now here's where it gets even worse. You know what else goes up when the vessel radius decreases? The pressure inside the vessel. So the blood pressure goes up, which can further damage the endothelium of the vessel, increasing plaque formation, which decreases the radius even more. This is a self-amplifying effect. It's why it's so important to stay on top of cholesterol and blood pressure and to take the modifiable risk factors seriously at any age. This can creep up on you before you know it. Okay, we should talk about risk factors and causes of atherosclerosis. When we talk about coronary artery disease, we're usually describing risk factors that promote endothelial injury, inflammation, and lipid accumulation. Risk factors fall into two categories: modifiable, meaning ones you can change, and unmodifiable, meaning ones you can't, like age or genetics, family history, those things. The major risk factors include, like I just said, age, family history, genetics, high LDL cholesterol and low HDL cholesterol, hypertension, high blood pressure, smoking, diabetes and insulin resistance, obesity and sedentary lifestyle, meaning you're not exercising, you're not moving around enough, chronic kidney disease, and inflammatory conditions like rheumatoid arthritis. Smoking accelerates endothelial dysfunction and increases clotting tendency. Hypertension increases shear stress on the endothelium. Diabetes promotes glycation, which is the tendency of sugars to bind to proteins, lipids, and nucleic acids, causing dysfunction. inflammation, and abnormal levels of blood lipids like cholesterol and triglycerides. Diabetes also promotes inflammation and abnormal levels of blood lipids like cholesterol and triglycerides. All of these converge on the same theme. The vessel wall becomes more inflamed, more permeable, and more prone to plaque formation and rupture. Okay, now let's talk about how coronary artery disease shows up in real humans. Earlier I mentioned stable angina. This is predictable chest discomfort that occurs with exertion or stress and improves with rest. The pain is often described as pressure, squeezing, heaviness, or tightness of the chest, usually retrosternal, which means behind your sternum, sometimes radiating to the left arm, shoulder, jaw, or back. It's not always pain. Some patients say it feels like I can't get a deep breath or I have indigestion. Stable angina typically reflects a fixed obstruction that limits flow during increased demand. And there's unstable angina, which is more concerning. Chest pain at rest with minimal exertion, increasing frequency or severity and longer duration. This suggests plaque rupture and partial thrombosis. And finally, and most concerning, myocardial infarction, heart attack. If ischemia becomes severe and prolonged, myocardial cells die. That's what myocardial infarction means. Symptoms can include intense chest pressure, sweating, nausea, vomiting, shortness of breath, anxiety or a feeling of impending doom. Heart palpitations is another one. And I have to say this clearly, not everyone gets classic crushing chest pain. Older adults, biological females, people with diabetes, they may present with atypical symptoms like unusual fatigue, shortness of breath, nausea, lightheadedness, maybe some epigastric discomfort. Those are still ischemia until proven otherwise. On physical exam, you might see profuse generalized sweating called diaphoresis, tachycardia, an elevated heart rate, blood pressure changes, or signs of heart failure like crackles when they breathe, abnormal breathing sounds caused by edema in the lungs, or pitting edema in the limbs. Okay, let's talk about the lab findings you may see with coronary artery disease. There are lab tests to help distinguish ischemia from myocardial infarction or heart attack. The first one, and the one that you're going to see all the time, is troponin. Troponin is the star of the show. It's a protein involved in cardiac muscle contraction, as well as skeletal muscle contraction. When myocardial cells are injured, troponin leaks into the bloodstream and it'll get picked up on a blood test. Elevated troponin suggests myocardial injury, commonly from infarction, but it could be other conditions as well. But we're focusing on myocardial infarction here, or MI. Another test that they don't do as much anymore, troponin's kind of replaced it, is creatine kinase MB, or CKMB. It's an enzyme. Creatine kinase is an enzyme in the myocardium, the brain, and skeletal muscle that helps synthesize ATP. Historically, it's important. It can help in some contexts, like detecting reinfarction. Someone's had another heart attack. We'll do a lipid panel. Check for LDL cholesterol, HDL cholesterol, triglycerides. This is more about long-term management than acute diagnosis of someone in the emergency room, but it's important so that you can manage risk factors. Depending on context, clinicians might look at some other labs like glucose or A1C, blood glucose, which should be under 100 or so, or A1C, which is the amount of glucose in your red blood cells, which is a longer-term measure of blood glucose compared to a simple blood glucose level, and that should be lower than 5.7 or so. Kidney function, important for contrast imaging and medication choices. If heart failure is suspected, you might get a test for brain natriuretic peptide, or BNP. BNP is a hormone produced by the heart that increases in the blood when the heart works harder, commonly used to diagnose and assess the severity of heart failure. Or you might test for inflammatory markers, which are not routine for acute coronary artery diagnosis, but inflammation is deeply involved in the disease. So how do we confirm that coronary artery disease is what we're looking at? Well, diagnosis typically takes place in the hospital and depends on whether you're dealing with chronic stable disease or an acute emergency. Obviously, you're going to see an ECG, an electrocardiogram. Sometimes you'll hear people say EKG. The only difference between those is EKG is the German spelling of electrocardiogram. The ECG is fast and essential. Ischemia can show changes like ST segment depression, a lowering of the trace between the ventricular contraction and relaxation, T-wave inversion. The T-wave shows ventricular relaxation. It might dip below the baseline rather than be above where it's supposed to be. In an ST elevation myocardial infarction, or STEMI, you can see ST elevation in specific leads corresponding to the affected region of the heart. But a normal ECG does not rule out coronary artery disease. Remember, an ECG is a test for the electrical activity of the heart. So it's only one piece of the puzzle. We do stress testing. For stable patients, a stress test provokes demand. A stress test is essentially using a specific test like ECG or echocardiogram while exercising and checking the results. An echocardiogram is an ultrasound of the heart, in case you didn't know that. Nuclear perfusion imaging uses small amounts of radioactive tracer and a gamma camera to create images of blood flow to the heart muscle at rest and during exercise. It is primarily used to detect coronary artery disease, evaluate blood flow, and identify damaged heart muscle. It typically takes about 2 to 3 hours to do, with risks including rare adverse reactions to stress agents, radiation exposure, and potential for motion artifacts. If a region is underperfused during stress, that supports obstructive coronary artery disease. You might see a coronary CT angiography, or CTA, a non-invasive way to visualize coronary anatomy and plaque, useful in select patients. A radio-opaque dye is injected into the vessels, and then a CT scan is done to get a detailed 3D image of the heart and coronary vessels. A little simpler than that is the gold standard for defining coronary anatomy, and that is coronary angiography. Sometimes you'll see people call that a cardiac catheterization. In acute coronary syndromes, you'll see people use this. A contrast dye is injected and an X-ray is taken, and that X-ray will show the outlines of the vessels as the dye moves through. You can see stenoses and treat with the same procedure. Speaking of treat, how do you treat these things? Well, it depends on the scenario. Stable CAD versus acute coronary syndrome. They're going to have very different approaches to treatment. Lifestyle and risk reduction. This is the foundation for everybody, no matter what. Stop smoking. Exercise. Improve your diet. Decrease your refined sugars and your saturated fats. Increase your fiber. Weight management. Try to stay under the obesity line. Blood pressure control. Diabetes management. These reduce progression and improve outcomes. There are medications for stable CAD. You've probably heard of statins. Statins are cholesterol-reducing medications. They lower cholesterol by reducing the amount the liver produces and increasing the liver's ability to remove cholesterol from the blood. Specifically, they try to lower LDLs, the bad cholesterol, and triglycerides, which is the main form of lipids in our tissues and blood. Statins also stabilize plaque in artery walls, reducing inflammation and the risk of heart attack and stroke. So how significant are statins? Well, according to the Agency for Healthcare Research and Quality, the most prescribed drug in the United States in 2023, which is the most recent data available at the time I'm recording this, was atorvastatin, whose brand name is Lipitor. So a statin is the most prescribed drug in America. But it doesn't end there. 4 other kinds of statins, including rosuvastatin, simvastatin, pravastatin, and lovastatin, are also in the top 50 most prescribed drugs in the United States. Combined, statins were prescribed to over 52 million Americans in 2023. That's almost 20% of the adults in the United States. Now here's the good news. In 1987, lovastatin, or Mevacor, was the first statin approved for use in the United States. A study was published in the Journal of the American Heart Association in 2025 that showed a 66% decline in coronary artery disease mortality from 1970 to 2022. Now, of course, that's not all because of statins. People smoke less now than they used to, and they're more aware of other modifiable risk factors. But you cannot deny the impact that statins have had on coronary artery disease. In 1970, 37% of all deaths in the United States were caused by ischemic heart disease. In 2024, it was closer to 20%. That is a huge reduction. Another treatment is antiplatelet therapy. These drugs are anticoagulants, commonly known as blood thinners. Often you'll see people using aspirin for this. It's very easy. Take a baby aspirin a day. It reduces clot risk. There are stronger blood thinners like Coumadin, Eliquis, Xarelto, but most people just take aspirin if they're not allergic. Beta blockers. They reduce the heart rate and the contractility, lowering oxygen demand and increasing diastolic perfusion time. Increasing time between beats, you get more blood to the heart. Nitrates, vasodilation and symptom relief, especially for people with angina. Calcium channel blockers are useful in some patients, especially with vasospasm. Remember, calcium ions increase muscle contraction. And ACE inhibitors, especially in patients with hypertension, diabetes, or reduced ejection fraction, which means the amount of blood that's still in your heart after your heart pumps blood out. ACE inhibitors are talking about angiotensin converting enzyme. If you go back to my urinary episodes, you'll see me talk about the renin-angiotensin-aldosterone pathway. Renin is an enzyme produced by the kidneys. It converts a protein produced by the liver called angiotensinogen into angiotensin 1. And then an enzyme produced by the lungs called ACE, angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2. And then a bunch of blood pressure effects happen after that, things that raise your blood pressure. If we inhibit the angiotensin converting enzyme, then we can manage blood pressure. So ACE inhibitors are that medication. But all of these treatments have a simple philosophy. Reduce the demand for oxygen. Improve the supply for oxygen. Stabilize the plaque and prevent blood clots or thromboses. That is for stable coronary artery disease. But if you have acute coronary syndrome, unstable angina, NSTEMI or STEMI, this is an emergency. Core acute strategies include antiplatelets and anticoagulation to prevent or limit thrombus, nitrates for symptom relief if appropriate, beta blockers in many cases with caution depending on hemodynamics, high-intensity statins, oxygen if the person's becoming hypoxic, and critically, reperfusion when indicated. Get the blood flow back. If it's STEMI we're dealing with, we need rapid reperfusion, most commonly via balloon angioplasty and stent placement. If that isn't available quickly, thrombolytic therapy may be considered in certain systems of care.
Look at him, eating whatever he wants, never gaining a pound. While I'm stuck with the boring special and can't lose an ounce.
How's your lunch, man?
Amazing. Yours?
So good.
Oh, I'm so happy for you.
Cool, buddy.
Weight loss isn't fair, but Mochi Health is. The affordable GLP-1 source that can fix your frustration with food.
So, same time next week?
No!
Definitely.
And your friends. Learn more at joinmochi.com. Mochi members have access to licensed physicians and nutritionists. Results may vary.
The secret is out. With millions of younger-looking customers across the country, Plexiderm is one of the most highly sought-after products on the market. It visibly shrinks under eye bags and smooths out crow's feet in minutes, and the effects last up to 10 hours. Influencers love it, magazines feature it, and people just can't get enough of it. As a matter of fact, Elle Magazine gave it an Editor's Choice Award as Best Instant Wrinkle Filler for 2025. In as little as 10 minutes, Plexiderm reduces the appearance of fine lines, wrinkles, and those dreaded under-eye bags. So yes, you can look years younger in minutes, and the effects last for hours. No surgery, no gimmicks, just results. The best news, you can try Plexiderm for only $14.95. Plus, get free shipping. Don't wait. Order Plexiderm today. Visit plexiderm.com/special. That's plexiderm.com/special. Paid for by Sheer Science.
Okay, so now what needs to be done if the coronary artery disease is severe or chronic? In these cases, revascularization is needed. The arteries that are failing to get blood to where it needs to be have to be fixed or replaced. One option is the angioplasty and stenting that I discussed earlier. If the artery or arteries are too clogged for that, it's time to consider coronary artery bypass grafting, commonly known as bypass surgery. This is common in multivessel disease or left main artery disease and in certain diabetic patients. A coronary bypass is a procedure in which surgeons use healthy veins or arteries from the chest, leg, or arm to bypass narrowed blocked arteries. So they extract a length of a vein from your thigh, for example. They pull it out, they go back into your heart, they tap into the coronary artery in front of its blockage, attach one end of the healthy vessel, then find the part of the artery on the other side of the blockage and attach the other end of the healthy vessel there. So the blood bypasses the blockage using this piece of vessel that we took from another part of your body. It is typically performed on pump, meaning the heart is stopped and they use a heart-lung machine to pump and oxygenate your blood for you, or off pump, meaning they just do the procedure on a beating heart. It improves symptoms like chest pain, reduces heart attack risk, and requires a 3 to 5 day hospital stay followed by months of recovery. If they have to do 2 vessels, it's a double bypass. 3 is a triple. 4 is a quadruple. So if you've heard those terms before, what's a triple bypass versus a double bypass? How many arteries are you doing? That's it. But bypass means exactly that. Bypass. Okay, what's the outlook? Prognosis. What happens over time? Well, it depends on the extent of the coronary disease, the degree of left ventricular damage, whether or not the patient has diabetes, if they're a smoker, or if they have kidney disease, how quickly reperfusion occurs during a myocardial infarction, and adherence to risk factor control, meaning how compliant is the patient on reducing their risks afterward. Stable CAD can be managed for decades with good outcomes if risk factors are aggressively treated. Acute myocardial infarction outcomes vary. Obviously, there are some people who just don't survive the first one. But early reperfusion limits infarct size, preserves ventricular function, and does improve survival. So the quicker the person can be treated, the better the chances. But the long-term major complications after an MI include potentials for heart failure from reduced pump function, arrhythmias, the heart rhythm might get all jumbled up, including sudden cardiac death, recurrent ischemia or reinfarction, and progressive atherosclerotic disease elsewhere like stroke or peripheral arterial disease. A powerful takeaway is this. Coronary artery disease is treatable and often preventable, but it is progressive if the underlying biology, lipids, inflammation, blood pressure, smoking, diabetes, is not addressed. Okay, so today we built coronary artery disease from its foundation bit by bit. The coronary anatomy, the physiology of perfusion during diastole, the inflammatory process of atherosclerosis, the difference between stable, narrowing, and unstable plaque rupture, and how that translates into symptoms, labs, diagnostic testing, and treatments from lifestyle all the way to stents and bypass. If you want a one-sentence summary, it's this. Coronary artery disease is the mismatch between myocardial oxygen demand and coronary oxygen supply, most often driven by atherosclerotic plaque formation and, at its most dangerous, plaque rupture and thrombosis. All right, that is the first episode of the new format. I hope you enjoyed that and learned something important about the clinical aspect of the human body. Coronary artery disease is the number 1 cause of death in the world among biological males and females. It's also the perfect foray into the clinical application of anatomy and physiology. Once again, thank you so much for listening. Can't say enough how much it makes me feel good when I get a note or an email or a comment, a review that is just telling me how much that they're being helped by this. And I really, really, really love that. Once again, I hope this podcast is helping you get your B or better in A&P. Good luck, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.